Without further ado, our first speaker has filled so many professional roles in his dental career that it makes me wonder if he ever has time to sleep. He is currently the Senior Vice President and Dental Director for Health Partners and a board member of the Wisconsin Collaborative Healthcare Quality. After spending 7 years on the Minnesota Board of Dentistry, he remains an active consultant. He is passionate about integrating medical and dental care and applying evidence-based research to care delivery. He has been a leader for many years in support of licensing and integration of dental therapy into dental practice. Here to discuss informed consent in dentistry, please welcome Dr. David Gesko.
Well, thank you very much. It's a pleasure to be here on Friday the 13th. So I hope that goes well for all of us, right? But it was kind of interesting driving in this morning, dark and rainy, and I've spent a fair amount of time recently in Arizona, and that's something that we don't experience very often, is dark and rainy. But anyway, it's great to see you all. Really a pleasure to be in this audience today. As was said, I've been fighting for dental therapy since the get-go back in 2008, and I started my position at Health Partners in 2008, and I think almost the first thing that I did was go to the State House and start arguing and debating with various councils and so on about the merits of dental therapy. So it's a pleasure now, 11, 12 years after the enactment of dental therapy and the education, and so it's like we're doing things really great. I recall the ads that were placed, full page ads about how devastating dental therapy would be. And I suppose that was an effective campaign at the time because it was the fear of the unknown. But now that we're through that all, it's just like now we can see. We all knew, but now we can see the craziness of those marketing ads, and that's taken place elsewhere in the country as well. And along with Katie, I've been all over the place to various states lobbying for dental therapy, and it's kind of cool to see the map here on the table as we came in to see all the different states that are turning purple. That's great. Good that it's purple, right? Because of the Minnesota Vikings, right? And Arizona was one of the last states to enact dental therapy, and that's where I'll soon be living, and so looking forward to getting involved with that as well. So, all right, with no further ado, let's get started. It's maybe a little bit more about me that's relative to this talk. I graduated from Minnesota in '86, which is, sadly, I'm sure many of you weren't born in 1986, but it does make me feel a little old, but that's nonetheless. And I did a general practice residency in Portland, Oregon in '87, right after graduation. I was in private practice in Bozeman, Montana for a short stint before I realized that I had the group gene in me, and I really wanted to be around other people rather than just be in a private single office. So I returned to Oregon where I had done my residency, and I spent 20 years at Kaiser Permanente, which is a system very similar to Health Partners, an integrated system that has both insurance and care involved with it. So I was there, as I said, for 20 years, enjoying myself, thinking that that would be it for me. And it's interesting, while I was in Oregon, I experienced denturism. And of course, initially when I interacted with denturists, coming out of dental school, I was the typical, like, well, there's no way that you can make a denture as well as these hands can, that have been trained through an arduous, expensive process. And boy, was I wrong. I really quickly realized how efficient they could be and how wonderful the product could be because they're focusing only on that. And so I quickly realized the place for a mid-level provider in practice and really enjoyed for 20 years working alongside denturists. Sadly, Oregon, being a pioneer in that, still took a long time to break into the dental therapy practice. And I think where they're at right now is maybe they've got piloting in place. If anyone knows more than that, you can correct me on that, but hopefully that will be going in the right direction. So that was my first exposure to mid-level providers, and I'm happy to tell you that I went in, like most dentists do, thinking like, oh, this isn't going to work, and was really sadly mistaken that I was wrong, and mid-level providers really add to the team. I came to Health Partners in 2008, and we've talked about that already, and I was appointed to the Board of Dentistry in 2012 and have served on the board for 7 years, and then continue, as was said, as a consultant. So I do case conferences all the time with licensees, so any licensee, and so we'll talk a little bit about some of those today as we talk about informed consent. I bring this up specifically because it gives me some credibility to talk about informed consent, and I'm thinking that we'll all benefit from the conversation we have about that. And so I'll tell you that I've been passionate about dental therapy, and to the point where, you know, I've been shunned as a leader and discarded, but nevertheless just persistent in my passion about dental therapy. So again, I know I'm repeating myself. It's exciting to be here today. All right, well, let's talk about what informed consent is and it isn't. And I want this to be interactive, so if you have thoughts, when I ask questions, I really would like your input on that. So don't hesitate to shout out, okay? So is informed consent this obligatory prescription or tool for educating patients? Would you say that's an accurate definition? Yeah, part of it, but it goes way be past that. It's not so much obligatory, even though it is required, but it isn't something that we just have to do. It should be a tool that really promotes our practice and promotes our relationship with our patients. Informed consent should be informative and integrated into the dialogue with your patient. It doesn't have to be formal or really so regimented that the patient's kind of wondering, oh my gosh, what's going on? You know, it should be really integrated into the flow of your care so that the patient really sees it as educational and informative. You know, is informed consent a barrier to treatment? Something that the boards impose and attorneys recommend? You know, when I came on the board in 2012, I remember that there was a lot of angst around the board. Any licensee in dentistry receiving, at that time, a letter from the board would just drive you crazy. I mean, you just practically have a heart attack. In fact, I tell the story that when I was on the board, I would receive every now and again mailings from the board. And when I would come home and see the pile of mail and see a letter from the Board of Dentistry, it would cause me to be really anxious until I then realized, oh, I'm on the board, so I get these from time to time about things. And but I will tell you that while I was on the board, and imagine this, but while I was on the board, I received a complaint from a patient. And so I had to actually go through that process myself, which is humbling when you're on the board. It was dismissed and everything was fine. I retained my seat on the board, but yeah. So I tell people all the time when I'm doing conferences, I'm not here to grill you. I'm not here to make your life difficult. Let's talk about this and let's learn from it. And I can relate. I can relate to what you're going through. So our vision statement at Health Partners, and I know I'm not speaking to a Health Partners audience, but is through relationships built on trust. So informed consent really builds trust with your patients, and that's what it's all about, and really is an opportunity for you to really cement the relationship that you have with your patient. You know, patients have had this legal right since the 60s. But still today, I can't tell you how many conferences I do with licensees on informed consent. So it's definitely still not ingrained in practice. And I'm not sure how well we were educated in dental school when I went to dental school about informed consent. It really is something that comes later. So hopefully with you, this will help you just integrate these things. Many of you I know are doing this every day, but it will help you integrate it even more into your practice so that you're on really solid ground. So patients have a right, to be informed of the procedures. We are all patients too, right, in the dental and the medical space, and we want to know what's being done to us, and we want to know what our options are, and we want to know what the risk of no treatment is. We all want this, right? And we research things when we're facing some kind of a procedure. Our patients absolutely deserve the same thing as well. They rely on us. Our patients rely on us to provide them with the kind of recommendations and explanations for treatment, because believe it or not, what's very fluent to us is Greek to them, right? They don't understand the kind of procedures that we're doing on a daily basis, the different materials that we can offer them, the pros and cons of those things, and so we really have to think about that in terms of the perspective of a patient, and the fact that if they're not explained well, they're probably a little embarrassed to ask some questions because they don't want to appear dumb or stupid, that they don't understand what it is that we're doing. But in any kind of profession, whether you take your car in for service or whatever the profession is, they have expertise that we don't, and so we need to seek that out when we make decisions. So how many of you have heard of the term PARQ? Yeah? A couple of hands? Good. I find that it's not all that common, though, and I'm going to suggest that this is something that you can take away from this presentation today and really incorporate it into your practice right away. So as you can see and as you can read, PARQ stands for Procedure, Alternative, Risks, and Questions. And when I'm making a note out about whatever procedure I'm doing, and I do a lot of extractions. I'm a general dentist, but I do a lot of extractions. I will note in the record, I will say literally, PARQ discussed regarding extraction number 32. I'll even then elaborate sometimes, discussed the risk of paresthesia on the mandibular nerve, some of those things. It doesn't have to be lengthy and verbose and cause you to spend hours to write your charts, but PARQ really covers it all. Really is a great thing to do. And let's even look at this diagram, which came directly from the Minnesota Board of Dentistry website. And so you'll see PARQ here, right? You see the nature of the treatment. You see the A, alternatives, and you'll see the R, the risks, and then the opportunity for questions. This adds benefits as well, which you can incorporate it as well. The benefits of the treatment are probably quite simple for you to explain to your patient. So PARQ, so the Minnesota Board of Dentistry is saying that this is critical in your documentation. And when it's lacking and a patient later has a concern, if it's not there, if there's not evidence of this, well, let's just say the board then will invite you for an opportunity to discuss that, right? And no one really wants that. Although I have fun in those conferences and try to allay fears and anxieties, but nonetheless, it's still a very stressful time for any of us. Yes, question, yeah.
So you write in your notes PARQ.
Yeah.
Can you elaborate with all the different things that are on the notes themselves, or you just need to?
Really good. Did everyone hear the question? I'll repeat it. Do I just simply write PARQ discussed regarding the treatment, or do I elaborate on each of them? It's the former. The board just, you don't have to write everything that you've said to the patient, or you'll be writing charts all the time, and you'll take them home to write. And so I don't want that. I don't think the board wants that either. So if the board sees that you documented a discussion of PARQ, and that you tell them if you need to that that's a normal protocol, and they'll see that in all your other records, that suffices. Yeah, you do not have to go through each of the sub-bullets under P, A, R, and Q. Good question. No. You know, I'll get to that. Hold that question, because I'll come to some of those verbal versus written. So really good. So the components, really, the discussion must be well documented as a part of the record, but you don't have to write everything that you wrote. And some cases, a written consent form is really a good idea. In our practice, and with my recommendations, it's extractions and endodontic procedures, really highly irreversible procedures are really good to have written consent, but not required. It's you'll have to use your best judgment in concert with the dentist or dentists that you work with. So, time for a story. I'm kind of known for stories, and I like stories to make points. So this is going back a long time, probably 88, 89, when I was first in practice in Portland at Kaiser. Because I was the new guy, right? I got the rather interesting referrals that nobody else wanted, and they let Mikey do it, right? So I got this woman on my schedule who I'm referring to as Diamond Lady. And at the time, she was what I would call kind of an old hippie. Portland had plenty of them. But she was a perfect example of this, because years ago in her life, she thought what would really be cool would be to have a dentist implant a very large diamond, probably in the neighborhoods of 2+ carats, right on the facial of, I can't remember if it was 8 or 9. Okay, so the tooth was devitalized. There was a root canal was done. You can imagine they took a round burr or whatever and just made this incredible crater in the facial surface of 8 or 9, and then with composite just luted this diamond into the facial surface of this tooth. Well, I mean, if you're thinking about a headlight, I mean, it's a good analogy. Well, I'm sure this woman thought this was pretty cool during her wild life, wild ages of her life. But she grew out of it, and so she came in and she said, I'd like it replaced. I'd like it removed, and I'd just like a normal surface there. Well, all I could see, and I was really naive in my practice, but I was, I'll say, smart enough to think, wow, danger, Will Robinson. I mean, there's a lot of, some of you are old enough to know that expression. But so I was very disciplined. I produced a written consent form and said, first of all, I'm not responsible for the diamond. If it gets broken or sucked up and we can't get it, it doesn't get caught by the trap or whatever. I said, I'm not responsible for that diamond. That was probably more than my net worth at the time. And then I also told her, and you can all imagine this, right, from what I described, the crown is worthless. I mean, it's all unsupported, and plus it's an endotooth, so it's dry and brittle. So I told her, yeah, I don't know if we can even restore the tooth. We'll have to see. And I also told her, which really burst her bubble, but I said, this isn't going to be covered by any insurance at all. And well, she was very offended by that, and why is that? I said, well, teeth don't come with diamonds, and so this is really out of the normal, so insurance isn't going to cover for this. Well, we got the diamond out. It was salvaged nicely, and so given to the patient. But exactly, the coronal structure of the tooth was worthless, and we ended up having to do a cast post core and a crown over that to restore the tooth. And everything came out fine. Cost her a fair amount of money, and but you know what the story all is about? The consent form saved me. Because had I not done that, and then everything would have happened where, cast post core and the crown and no coverage and all of that, she would have been all irritated, and as it was, she wasn't happy, but she understood that, you know what, this was her doing, and she didn't have a lot to talk about. So that's my story about Diamond Lady. Never did I think that when I was going through that process that some 30-some years later that I would be using that as an example for today's talk about informed consent. It's great. So malpractice insurance carriers sometimes will require a written, so this is due diligence that you should do in your practice. You should check with them to see what do you require and what don't you require. And I'm not sure if it were to come to a trial or a decision, if their requirement for a written would oversee what the state requirement is really by the board and the standard of care. So use your best judgment on that one. Okay, so clearly this is my point, really by law it can be verbal or written, and that's why I'll document the fact. It's important to document the fact that you had a verbal discussion. But it doesn't have to be a written consent that they have to go through and sign. In some cases that's good, but you'll have to use your best judgment on that. So again, why informed consent is so important. We've already made some good points on that, but the highlighted section here really makes the point come home. When you don't have good informed consent and you have a broken or impaired relationship with your patient, it will lead to dissatisfaction for sure, and it may cause the patient to leave the practice. I see it all the time. And so none of us want that, right? We want our practices to grow, we want our patients to be happy, and we certainly don't want contention, because those patients that leave a practice over any kind of dispute like that, right, just like us, we tell lots of people. All it takes is going out to dinner and having a bad experience at a restaurant, and we tell a bunch of people. Certainly we do the same thing with dental care or with medical care. We all know ourselves, right? And so our patients will do that. We don't want that. That's why it's really important that those patients are happy and that they're informed and they can tell their friends about the practice in a very positive note. Okay, so challenges. How many of us are seeing, extremely diverse population these days? I really want everyone's hand to go up because, yeah, it's really absolutely the norm. When I grew up in Minnesota a long time ago, diversity really meant you might be from North Dakota, and so I'm not exaggerating. I'm not trying to make fun of a serious issue, but it's true. That's the way that things were, and it's changed significantly. Who would have ever thought that Somalian refugees would decide Minnesota was a place that they wanted to come? I think they were sold a bill of goods there or something like that. But I ran into a German population in North Dakota that were immigrants, and they were told that, and they were in the winemaking business, and they were told that this part of North Dakota would be perfect for wine production. Well, can you think of any place in North Dakota that would be, suitable for growing grapes? I don't think so. So language barriers, socioeconomic status, all these kinds of issues that we deal with on a daily basis become challenges to informed consent, and we have to be able to make sure through translators or what have you, that informed consent message gets across. It would not be a good defense, and it would not stand If you said, well, I did what I did to all my English-speaking patients, it's their problem that they didn't understand what I was saying. That won't fly. And so you have to think about how you're going to send that message so that they can understand it and really take it in and be able to really act on it just like any other patient would. Questions about that at all? Do you have any stories about, as we go along, if you have a story about a patient related to what I'm talking about, please raise your hand. We'll have plenty of time. We'll end on time. Okay. Dental lingo. Okay, we love that, right? When we come together at a meeting like this, we might fall into that. We might talk about a interesting patient we've had recently. And in every group of people that do whatever has their own lingo, correct? So what is dental lingo? Give me some examples of what dental lingo is. Caries? Yeah, excellent. When I was in dental school and first introduced to the term caries, I had no idea what it was until I was informed that that was the same as a cavity. Oh, okay. Well, caries, interesting. I mean, another true confession, when I was in dental school and understood that as blood flows through the body, it actually goes through the teeth as well. I had no idea of that. And I don't have any qualms telling you that. But it's true, that. And do you think our patients understand that either? I don't think so. So yeah, don't use the word caries when you're talking to a patient because it'll go right over their head, and they'll be embarrassed to ask you what that means because they'll think that they should know that. What are some of the anatomical terms that we use? Yeah. Right, north, south, east, and west, mesial, distal, buccal, lingual, all of those kinds of things. That'll go right over their head as well. Who would expect their patient to understand that? What an MO means, or a DO, or that you have a lingual lesion. Nobody understands that. And so I guess the term that we are all used to is, dumb it down, not to be inappropriate, but you need to speak at the level of the language that the patient understands. And so don't use those terms when you're talking with a patient, or else it'll go right over their head, and then later it'll come back to haunt you because they might say, well, he or she used these terms that I didn't understand, and I was embarrassed to ask because I thought maybe I should know that. Yes?
Sometimes people even ask, you're talking to your assistant, you say buccal lingual, talking language like that.
Yeah.
People, they forget words because you're hearing all these terms. Oh, what do you mean by all that? So I just use these terms. I won't elaborate on it. You make fun of it a little bit.
Yeah, or you tell them, oh, it's the equivalent of north, south, east, and west on a tooth, and it's just language that we use internally. Sorry about that. I shouldn't have done that. Those are the kinds of things that I would recommend that you think about. It's easy to get caught up in that, though, right? Very, very much, because we're loaded with that kind of stuff. That's what we're all been educated with, and so we use it fluently, and we sometimes don't even know that we're using it. Okay, so there are three basic types of informed consent, and we've talked about that a little bit: implied, verbal, and written. Who would venture to know what a definition of implied consent is? Yeah.
I was taught in dental school, and I graduated less than 10 years. Kate walks in the door. You're on.
But we're old now, so you realize it, and so things change. I agree with you, but essentially, like if you have an emergency that comes in, a child that maybe avulsed a tooth, or there's bleeding everywhere and stuff, and they come in for treatment of that, and you dive right in and treat it, I think there's clearly an implied consent there. Clearly they came in for your care, and it was an emergency, and you jumped right in. Question? Yep. Yep, and I think that that would be a very solid foundation to stand on for a lot of things. But I think to really protect yourself, you need to limit implied consent to really a small segue of procedures and things. Brian? Yeah.
Well, I was going to say that implied consent to me is that you're voluntarily going along with what we're doing. And you use the hygiene example where I just come in and say, okay, we're doing a filling, and most people know what a filling is.
Yep.
Most people know what things are. So it's
Yep.
sort of like that's implied consent. So they're going along with it on their own terms.
In these, I've seen situations where when you say I'm doing a filling, might not cut it completely. There's still some practices that will use amalgam versus composite, although probably few and far between. But I think it's important to say, you know, I'm going to do a white filling or I'm going to do a silver filling. That probably is important too. I left out in my resume that my wife and I have a son that's just turned 31 earlier this week, but he's a fourth-year dental student, and so that's kind of exciting for Dad, and so we've had lots of long conversations about all kinds of things. Can you imagine going through dental school and having a father like me? You know, but nonetheless, it's been very exciting and fun, but. He was taught amalgam in pre-clinic on typodonts, but it's not available at all for patients, patient care. Now he's also going on rotations across the country, and I think he's using amalgam in some of those public health clinics, where I think it's appropriate when you have a patient that has really high needs and really doesn't know which end of the toothbrush to put in their mouth, that you use amalgam, where you don't have to worry about you know, recurrent decay as much. Yep.
We've had in our public health setting, of course, we see people like that, their whole hygiene is a little bit, their diet is a little bit, so they're using amalgam. And again, that's one of those phrases, hey, we can put an amalgam or a composite.
Yeah, yeah.
They have no idea what the difference is until they go home and look in their mouth and see the black filling.
Right.
And then they get all that talk. So.
Yeah. Oh, I've seen that in our practice where that's happened. And it's just sort of a breakdown in communication, or sometimes it's an example of where we're on autopilot and we don't really perceive that. But the world has changed and is changing, and it will be soon that, you know, amalgam is just something that will be the same about talking to your kids about a dial phone or something like that. You know, they'll just not understand what it means, or a VHS tape just won't understand what it means. So yeah, it's one of those things that sadly that I think is moving in that direction.
Well, and to that point, when you do consultation and give the options, I think a lot of people be surprised at how often people like that. You know, that's awesome.
Right, right.
I love that.
Well, Katie, it has everything to do with the conversation that you have. If you simply just say, would you like a white filling or a black filling or a silver filling, you know what everyone's going to pick. But if you say to them, you know, there are white fillings and silver fillings, but for you, if I can't do a white filling well because your gums are really kind of in a bad place, and I can't get a good seal, and it will leak, and you'll get recurrent decay, and you'll be back in to see me. Whereas if a silver filling, I can get a really good seal, and we can get on top of your hygiene, and then hopefully maybe down the road we can replace those with fillings that look more natural. You know, it's all about the script. So here's another idea. You have a written consent form, let's say, for a procedure, and you just simply just say, you need to sign our consent. You don't explain it. You don't go through it with them. You just hand them a clipboard. Will that suffice? Yeah, I see some head nodding there. It won't. You know, it actually won't. If later there's a problem and the patient just says, he or she gave me this clipboard and it was like reading Greek or something like that, and I didn't really understand anything that it said. I asked some questions, but didn't get good answers and stuff. That's not going to work. It's as if you didn't give a consent at all. So a consent is only as good as the patient understands it. That's why the Q is in PARQ. Questions. Do you have any questions? Does everything make sense to what I've said? And do I need to elaborate on something, or is there something that maybe you didn't understand well? And I'll write that sometimes in charts too. You know, once you've been on the board of dentistry, your charting really changes because, you know, every time I write a note, I envision the complaint committee sitting around a table discussing what I wrote. So I'll write PARQ discussed regarding extraction number 32. I might, as I said earlier, add something about paresthesia. But I also will write patient had no questions. And believe me, if the board reads that kind of a note and they see that it's a norm for you, you're really on solid ground. You're just on excellent ground. And it's not just about the board. I don't want you to make that the gold standard. It's the right thing to do, right? It's the right way to treat our patients. So here's a link. I don't know if you're going to get, do you have copies of my slides? So, yeah, well, maybe you will get them. There's a link that takes you to the necessary rules related to informed consent, so you can fact check me and you can read more about some of these things. So, and really exciting for me to read the updated rules in Minnesota that doesn't just use the word provider or anything generic like that, but it includes advanced dental therapist and so on. So isn't that great? I mean, I just, when I read things like that, it just makes me feel good that, you know, we did all the hard work and we got where we're at, and we're number one in the nation. Sure, Alaska had it before, but it was limited for just a tribal population, so Minnesota clearly was first on the map. That's very exciting. Questions about that? Okay, so again, there's some redundancy here, but sometimes redundancy about some issues is good because it makes the point. So the requirements again, the nature of the chief complaint, and this will also prompt another acronym, which I'll ask you what you think that is. Outline the proposed treatment, the prognosis, is it going to, you know, what's the likelihood of success, any risks, are there reasonable alternatives that the patient should consider, and then what are the risks and consequences of no treatment. So when you hear the number one, the nature of the chief complaint, what acronym do you think about there relative to charting? CC? I was thinking of something that we all used this morning before we came in the shower. SOAP note, you know, subjective, objective, assessment, and procedure. So SOAP note is right up there with PARQ. And in fact, PARQ finds its way into a SOAP note. So when a patient comes in, many times a nice, short, abbreviated way of charting is to follow the SOAP process. Were you all trained with that in mind? Yeah, okay, good. SOAP note is pretty prevalent across the country. And so, yeah, subjective, again, that's the chief complaint. S might be, you know, my upper left is killing me, in quotes. Or, you know, maybe, and I know you handle these kinds of things, but your scope of practice is maybe the patient comes in and says, you know, my lower left tooth broke. And then you go about diagnosing what that is and how you're going to treat that. Objective is, you know, you look at the x-ray and the clinical exam and you say, number 19, you know, both lingual cusps are broken. And assessment is, you know, broken tooth. And P is the procedure that you plan to do to remedy that. And then that's where the PARQ reference goes in that P section. All right, great. Questions about that? Anything? Can you still hear me well in the back? Yep, okay. Ethics versus law. This is an interesting discussion. The process of informed consent is both an ethical and legal imperative. And I think we've spoken to both of that, right? And you'll recall just recently I said something. It's not just about what's required, what the board requires, but it's the right thing to do. That is right there the difference between ethics and law. Law enforces the behavior that we're expected to follow, while ethics suggests what we ought to follow and helps explore options. Law sets minimum standards of behavior, while ethics sets maximum standards. So we all want to treat our patients ethically, and when we are patients, we want to be treated ethically. We want our providers to treat us in the way that is the right thing to do. And that's the standard. If you follow that standard, complying with informed consent is not going to be a problem as long as you document it, because that's the way that you practice, that's the way that you think. You give people options, you let them be a part of the discussion and decision-making process, and then you move on. It really doesn't have to be more complex than that. It doesn't have to slow you down. The courts view the informed consent requirement for a healthcare provider as a requirement to discuss sufficient information for the patient to make a controlled decision before undergoing irreversible treatment. A patient's consent must be voluntary, meaning there's no coercion, persuasion, or inducements, and can be withdrawn at any time. So be cautious of putting your own overlay on recommendations, but be more generic and holistic with them and let them make the decision, because we're all wired very differently, and men and women are different in that regard. And it's interesting in terms of when you ask a patient if they're satisfied. You've all seen patients that come in that might be missing every other tooth, and might have just what you would think clearly is like not a very good smile. But when you ask them, are you happy with your mouth and with your oral health? They might say, yeah, I'm delighted. Everything's working fine. I don't have any pain. Everything's good. Doesn't bother them to be missing 8 or 9. It's not probably something that we can relate to in this room, but everybody's different, right? And so don't let your own overlay influence that. Then you might have another person that comes in that has beautiful teeth, unrestored, and they're embarrassed to smile because they want it to be brighter or whiter, possibly glow in the dark, and so there's all kinds of people, right? That's my point. Failure to obtain consent is considered a breach of duty, specifically battery. What's battery in a legal sense? Yeah, harming somebody. Here's the Google definition. Battery is an unlawful application of force directly or indirectly upon another person or their personal belongings, causing bodily injury or offensive contact. Yeah, you don't want to ever be accused of battery by doing something that harmed a patient, and it can be alleviated by just good conversation with your patients, not complex, not difficult, documented well, and this will never be something that you experience outside of this talk today. So what's informed refusal? Before you see it there on the screen, but before you read that every word, tell me, what is informed refusal? Someone? Exactly. What are some examples that we might experience on a regular basis with informed refusal? Periodontal disease. That was the top of my list. Yeah. You can tell a patient that they have, you can show them, they have bone loss and pocketing and bleeding, and then you can describe the treatment choices. And we've all done this, right? And you do that, and the patient says, well, that doesn't sound comfortable. That doesn't sound like something that I want to go through. to be numbed and deep scaling. I mean, that's not a term that most patients would find interesting. So they might say, you know, I'm just fine the way I am. You need to document that because that's informed refusal. If you don't document that, you could have problems going forward where the patient then starts losing teeth because of periodontal disease and then comes back at you and said, why didn't you tell me how important that was? If you document that in the record that you discussed the diagnosis of periodontal disease and patient refused treatment, that's important. And you all know that, right? Other examples of informed refusal? Yes, Bill. Okay. Good. Right? That's a part of a thorough exam, absolutely, and telling them that there are things that we can do for these. And in some cases, you know, it's okay. You know, when I was in private practice, I'll once again, true confessions, and admit that, you know, I would see patients that would have, say, 19 or 30 missing, and that tooth might have been missing for 20, 30 years or something like that. And I would tell them how much they needed to have that space replaced, and that if they didn't, you know, that the upper tooth could do all kinds of crazy things too. Well, I wasn't wrong in doing that, but I think my motives might have been more self-centered than patient-centered. You know, I was in a situation where I needed to make money, and I wasn't unethical, but I was telling them something that, you know, they looked at me sometimes and said, well, that tooth's been missing for 25 years and I'm doing fine. You know, it's at that point where you ought to say, you're right. I just wanted to let you know there are options to treat that tooth, but the fact that you're deciding to keep it as is, that works for me. That I can understand where you're coming from. Yes? Oh, refusal to treat a patient at all. What are some examples that might drive that? Give me a scenario. Oh, under the influence of something, which that something has expanded now in Minnesota, right? Yeah. In terms of legally. Oh, that's something that's very real. That's very real in our practice, and you can document the fact that a patient came in obviously inebriated or whatever word you want to use, and that you explained and they admitted to it, and you agreed or decided that it would be best to defer treatment. Yeah, Brian, did you have?
Well, a question on that is, I've treated plenty of patients that are using it now legal. And I mean, am I supposed to decide myself that they have the capacity to understand what we're doing? Or is it better for me to just blanket say, well, I don't know that you have the capacity because you're high, so let's defer this?
Yep. I think you have to use your best judgment on that, and I don't think you'll ever be faulted by using your best judgment. And you have to decide what procedure you're doing on them today, or if you're presenting a treatment plan, which, you know, I'm saying that because they may not have the capacity, going back a few slides, to really accept your informed consent because they may not all be there. And so it makes me think of another story, and I went into the room here in our clinic care system to see a patient who I knew was over 100 years old, like 101 years old. And it was a gentleman who was a retired physician. And his chart clearly indicated that he wanted to be referred to as doctor. Okay? That's okay. I was like that for a short period of time after graduating from dental school, and quickly had it printed on my checks, and then realized, I don't think this is working in my favor. Actually, everything seems to be costing more. So I had it removed, and so people that know me well know that my name is David. In front of patients, that's okay to refer to me as Dr. Gesko, but otherwise my name is David. But anyway, so I walk into this room, I greet this patient. The assistant that I'm working with that day had already seen him and taken his blood pressure, and she remarks to me that his blood pressure is high. Well, I saw it. I don't remember what it was today for the purpose of the story, but it was well within a range that I was comfortable taking this single tooth out with local anesthetic alone. So I proceeded, everything went well, and things were great. I left and did the charting. I came back into the room before I parted company with him, and the assistant again, with kind of an edge, remarks, well, his blood pressure is still high. And so I paused for a minute. I was a little irritated by the implication that I wasn't managing the patient's blood pressure. And I thought for a second, and I look at the patient knowing he's a physician, and I said, you know, at age 101, I think it's good to have a blood pressure. and he laughed, as you just did, and he quickly said to me, yeah, Doc, what do you think? Should I start jogging? And so I guess the whole point again then is to decide, you know, okay, you've got to use your best judgment. That's all the education that you have, whether the patient comes in high or if other things are happening, you have to decide how to proceed, you know, based on the procedure that you're doing and the level of risk and your comfort with that. I don't think you'll ever be faulted for that.
Well, and that's why the health history can be so important too. We get a lot of detail patients in our practice. Some of those questions are, if you use this in the last 72 hours, and I gave you epinephrine, like we're gonna have a huge problem. So, you know, having that part of the notes for that you're reviewing for medical straight after questions.
Yeah, just documenting the fact that, you know, reviewed health history, it doesn't take long, and with the electronic record system, whatever one you have, there's a way of loading presets in there and you know, building notes so that they auto-populate and then you just add to them. This doesn't have to be long and arduous and time-consuming at all, and you could do just an excellent job. Well, let's talk a little bit about standard of care. Medical dental malpractice falls under state civil tort law. Negligence is the standard of conduct to which one must conform. In order for a plaintiff, typically a patient, okay, to successfully file a lawsuit, 4 conditions must need to be present. So duty, there must be evidence of a sustained provider-patient relationship and evidence of a substantial medical dental condition. Okay, duty is one. And then breach of that duty. So not meeting the standard of care when a provider by omission or commission fails to meet what prudent individual with the knowledge, skills, and experience would do. I think we throw around the term standard of care a lot. I think we'll sometimes use standard of care to affirm our beliefs. You know, might say, well, that's clearly the standard of care. What are some examples of that we might use rightly or wrongly about standard of care? Can any of you give me an idea about that? Bill, you mentioned a edentulous space a minute ago. What could you do that might imply that this is the standard of care? What if you told a patient, hey, the standard of care with a missing tooth like that is to place an implant? That might be a stretch. I know implants are really a part of our practice and they've come a long way, but you know, when I first got out of dental school, there weren't implants, and you know, we did bridges, and I did one on my father in dental school. So it was probably 85, and it was from 17 to 21. It was all gold. He actually leans a little to the left, I think. He's still alive. He'll be 97 here shortly, but and that bridge is in perfect condition. And so, aren't I great? You know, but I'm just saying that the standard of care can vary. Some people might think, a 4-unit gold bridge with, all gold ponics might be over the top, but, it really worked well for him, and it's worked very well for his entire, adult lifetime, really. So yes, be careful of throwing the word standard of care around, because it's really kind of a legal term that's defined by a lot of lengthy processes. And then also I want to let you know that, and this is very real to me when I'm taking teeth out, I'm held to the standard care probably of an oral surgeon. And so I need to pick my cases carefully and know that I need to pick and select the cases that I do that I know fall within my scope of practice, because I'm not an oral surgeon. And so that's true, kind of for all of us in terms of that. We need to be mindful of that. That shouldn't make any of us afraid. Just be aware of it. And then the third thing is that there has to be harm, okay? And that there has to be causation. And causation is what? What you did caused the harm, all right? Causation is something that people will confuse sometimes with oral overall health and say, periodontal health is causative of diabetes. Well, no, it's not, because edentulous people get diabetes. So it's suggestive, and it's definitely associated with, but it's not causative. Causative means that what I did absolutely caused the harm that you're suffering, that you may then bring suit against me. That's the really black and white part of it. Questions about that? Okay. Concept of duty. So, the clinician here, including therapists, patient relationship places a responsibility of duty on all of us. Okay, the duty of sufficient disclosure is informed consent law, and that originated from medical and dental malpractice. That's what we're here to talk about. Usually there are two components: departure from the standard of care resulting in a proximate material injury, or proximate is one of those fancy terms, right? I told you not to use them, and I used one, but proximate means that it resulted as a part of the procedure you did, or it was causative, okay? Failure to secure sufficient informed consent. So you did something that didn't turn out well, that you caused, and you didn't tell the patient that it might happen. That's not a recipe for success. That's a recipe for having a Zoom call with me on the board. I don't want to meet any of you in that capacity. Case law, there's all kinds of, here's an example. Royable versus Bell ruling involving an alleged failure to obtain informed consent in connection with a apicoectomy or a surgical root canal procedure on tooth 20, resulting in pain and paresthesia. So the plaintiff, or the patient, brought that, claimed that the dentist failed to advise her adequately, and that she could have had the tooth extracted instead of this apicoectomy procedure to retain the tooth. So, interesting case, right? Complex dental procedure, irreversible, harm resulted, paresthesia from the procedure, and she brought a lawsuit and she prevailed. Summary judgment was granted to the, well, no, she prevailed in the end. First, they said that the dentist was okay in doing that, but upon appeal, they reversed it and assigned it to the plaintiff or the patient. So these things really do happen. I see them all the time. One of the things that results in review by the Board of Dentistry is anytime that there's a malpractice claim made. So whether it's an extraction of the wrong tooth or a filling on the wrong tooth. Say the patient comes in for a DO on 12 and you do a DO on 13. Well, that stuff happens all the time, really. But whenever those kind of things result in a malpractice claim, then the Board of Dentistry gets informed, and then you discuss that. And so you discuss, well, how can you how can you really assure that this is never going to happen again? You walk through those things, and that's the result of the conferences that I do. So conclusions. Informed consent, is a complex process involving dynamic interaction of society, ethics, individual rights, law, and healthcare. Court rulings help advance certainty, clarification, and understanding to this process, which benefits the public. Remember what the mission of the Board of Dentistry is? I remind people of that. It's what? Do you recall? Protection of the public. That's what the mission of the board is. So it's all about protecting the public from harm, and that's what we're talking about today. It is imperative that general dentists, therapists, everyone in the room stay vigilant, up to date with current informed consent rulings, promoting the provider-patient collaboration in the treatment, improves communication and understanding, and making this whole relationship good. One of the things that I remember from dental school, and they didn't talk much about the whole kind of patient management, practice management concept at all. But one of the things that one lecturer said to us once, and I think it's true, if you have really a good relationship with your patients, if they like you, if they trust you, if they respect you, they'll forgive a multitude of sins, really. Yeah? And if they don't like you, if they think you're arrogant or whatever, if they just don't connect with you at all, well, then you really have to operate at a higher level. Well, you should operate at a real higher level, but, the whole thing is if you have a great relationship with your patients, these things that we've talked about today still need to happen, but you're going to do really well. And you all know that. You experience that all the time. Treat people well, they'll treat you well. It's just the way of life. So I hope there's some questions. We had some great questions during the conversation that we just had. So anybody else? Bill? Okay. If I understood the question, like, what are the most common kind of instances where people come to the board? Yeah. Well, I'll answer it this way, and you tell me if it's sufficient. But some of you have maybe had an audit by the IRS. Hopefully not. I haven't. But the thought is that if you get audited for some reason, there's something that drives an audit. Is the IRS just going to look at that aspect of the breach? No. They're going to look at everything. It's kind of like, I don't know, there's various examples of, the camel's nose under the tent or whatever. I don't understand all of those. I can't keep all those analogies straight. But they're going to look at everything. The board does too. So let's say that you forget to take your CPR requirement, and for some reason that comes to the board. That's why Katie doesn't work for Health Partners anymore. No, that's not true. That's not true. Katie and I are good friends, and she knows we kid each other. But anyway, so the board might review this, and they might look at everything else, Bill, and they might realize, they look at charts and they say, boy, you're lacking in your informed consent, for sure. A lot of times the complaints that come to the board are filed by not just the public, but the staff, disgruntled staff that thinks that the dentist is a jerk. I'll be polite. And so the board looks at things and can see a multitude of sins sometimes. So yeah, it's informed consent is something that the board always looks at whenever they're looking at a complaint in general, and has the ability to look at that, and sometimes will close the complaint on topic X, but then they'll advise a consultation with me about informed consent or record keeping or something like that. So yeah, it's amazing how that happens. So it has to operate all the time. Is that okay, Bill? Is that sufficient? Push me more then.
Like the clinical example, what providers do clinically that is.
It's all over the map, but when anything doesn't go well, or something goes wrong, kind of the same side, our society these days is much more anxious and inclined to hit that button or pull that lever. And then, but it's generally initiated by something not going well. You know, continued pain after a procedure, the bite is off, aesthetics don't look good, any number of things. Yeah, I had a case recently that where the patient went into this dental office and had really extensive needs and needed the remaining lower teeth extracted. And patient came educated, had really gone online and looked at the options and really wanted an implant-supported fixed denture. Didn't want anything that came in and out, so wanted, you know, like a 4-on-full kind of a thing. Well, the dentist agreed to that and said, absolutely, I can do that. And here's another thing that was there. The patient said, my upper teeth, they're being treated by another dentist in the community, and so don't worry about my upper teeth. I just want you to do this lower restoration. Well, what kind of red flag is there? I'll stop right there for a second. Yeah, danger, Will Robinson, once again, yeah. You know, when you're taking care of a patient, you're taking care of the whole patient. If somebody comes in and says, I only want you to look at the lower left, you know, the rest I'm really happy with, but you come recommended to treat the lower left. I don't think I'd engage in that at all. That would be something. This dentist did, though. This dentist said, oh, okay, and proceeded to have the remaining lower teeth removed, and then started working on the steps necessary to do the implant-supported fixed denture, and realized, quote, it was over his head. Well, it resulted in a complaint to the board, as you can imagine, because the practice dismissed the patient after removing all his lower teeth with the thought that it's over my head. Well, I guess it's good on one hand that the dentist recognized that and didn't go in and do something that might have been even worse. But the patient was really perplexed. Well, I've paid you all this money. You've edentulated me. You've taken my remaining teeth out, and now I'm just out in the cold again. Well, that's all that we're talking about here is informed consent and coming together on what the treatment plan is and how everything gets worked out. And so that came to me, and I discussed that with the dentist, and he in this case had great learnings from the case, learned a lot from what happened. And it was kind of at a point where it said like, oh, okay, are we done? And I said, no, we're not done. That patient's still out there. He's paid you a lot of money, and he doesn't have any teeth on the bottom. And what is he supposed to do? Well, I helped him understand that needed to refund all the money that had been paid, and imagine that. He took my recommendation, and he did, and the patient was happy and moved on. But there are examples of this all the time that happen where, you know, maybe it's a little bit, some of it out of your scope, but you're part of the treatment team, and it's all important. Well, I think we're close to our time, and so any last question?
I do have
A story.
To make myself even sound better.
I love stories. Love stories.
You might remember this, but, I mean, because it doesn't even have to be something as big as an extraction, but kid came for an exam, and it's all part of note templates are, I mean, it is bored, good. said that everything was explained, agreed to treatment, da-da-da. I saw the kid, I didn't do the exam. And I did filling on A and sealant, da-da-da. Mom called, I raped. Screaming at the front, came back in, not for the filling, for the sealant. She claimed I had touched her kid without her knowledge and put sealant on their teeth, and it was a big blow up for the sealant. But there was plenty of documentation, luckily, saying that like this was explained, there was consent, from me to the assistant and everything, so it ended up fine, but it doesn't have to be something as big as an infraction for you to get in trouble.
Really good point.
And that, I mean, that went all the way up to the lawyers.
Yeah.
So,
Yeah.
I mean,
I think the expression that we've heard from time to time is much ado about nothing. You know, the board will get those kinds of complaints because when they get a complaint, they have to act on it. It has to go through the process. And many times that's the conclusion. This is much ado about nothing. There's nothing here. Most of the complaints are dismissed. And there is no basis for it. It's just like, you know, maybe the patient submitted a complaint to the board because they really didn't want to pay their $1,500 bill or something like that. And so I'll take the case to the board and maybe they'll dismiss it. That's not the way the board works. That's not the realm of the board. Great example, very good to this audience as well. I was hoping I didn't use examples of things that weren't in your scope, but that's helpful to bring that back to say, yeah, it's all about, it can happen really innocently sometimes. Don't fear the board. The board has changed a lot. I like to think that I had something to do that when I was president, that really tried to deal with some of the people that were involved with the board that just thought anyone in dentistry was evil. So it's changed quite a bit. It's a much better place, I think. Yeah, in fact, quick story to end. It was 2016. I was president of the board, and one of my staff members at the administrative office that I work at came down the hall, poked into my office, and said, "David, do you know a dentist by the name of Walter Palmer?" Okay, some of you may be newer to the profession than that, but that was the lion killer, the dentist that killed Cecil. Yeah, interesting. 2 weeks of my life was gone. I received death threats. It was all over the world, right? It was everywhere. And any time it appeared in headlines around the world, Walter Palmer's name was preceded by Minnesota dentist, Walter Palmer. And so here's an example of how in the dental profession we're held to a higher standard. Doesn't matter, one can only speculate if Walter Palmer were a plumber, if those headlines would have said Minnesota plumber. I don't think so. Because we're in healthcare, because we're in a profession like we are, we're held to a higher standard. And that doesn't mean just when we're seeing patients. It means when we're at happy hour on a Friday evening and something happens, our conduct is still professional. And that came to the board, of course, and there's clauses in the board that say conduct unbecoming a professional. Didn't really go anywhere because Zimbabwe never filed charges, and I'm sure that there were arrangements made, but it all kind of went away. But there was a while there where I had police protection just because people thought if you don't take his license away, then you deserve. I got emails. If you don't take his license away, you deserve the same fate that lion got. So that was kind of fun. Anyway, thank you very much. I had a great time talking with you this morning. This is where I'm headed as of January. I'm retiring from Health Partners and moving to Tucson. And I want to stay involved in the profession, but I did sell my two snow blowers a few months ago, and it was nearly the happiest day of my life. Thank you very much.